Here is your station. You have 1 minute, but we can begin earlier if you happen to be ready earlier.
So this is just an examination station.
Yes,
Yes.
but read carefully.
Yeah, I understood.
Okay. So if you've read and understood, considering each surgical or clinical examination station, please begin.
Um, who will be the actor? You or Dr. M?
Ian,
Okay. Good evening. My name is Dr. Vijay Kumar. May I know your name and age, please?
Robert, I'm 55 years old.
Hello, Robert. Uh, so how are you doing today?
I'm not well. I can hardly breathe.
Okay. So may I know like what is the reason why? Uh,
Remember, this is examination station.
yeah. So okay. So your post-op day 8.
Go ahead, do the examination. You've
So
already, yes.
in examination, I'll go by inspection first. Inspection, I'll inspect the upper respiratory tract near trachea, whether it is in the midline or not, respiratory movement, whether the breathing is diaphragmatic or not.
Okay.
Then I'll observe for clubbing, pallor, cyanosis, any lymphadenopathy. Though that is a part of general examination. Uh, then I'll observe for chest expansion, whether it is symmetric or asymmetric, or whether there is one-sided paradoxical breathing. Um, then I'll try to see the pattern of breathing. Next, I'll try to palpate. Palpation will begin with uh, palpating the whether the movement of the lungs is symmetric or not symmetric in the front, in the back. I'll also try to see the heart, apex of the heart, and whether I'm able to feel any palpitation or not. Then I'll also uh, see for vocal resonance by asking the patient to speak a particular number or word and then feel for vocal resonance. Then I'll try to do the percussion. I'll do the front, in the back. I'll see how the breath sound, how the percussion tone is, if at all it is getting dull or not. The next step is auscultation. I'll observe for breath sounds in the front, in the back. Then I'll observe for heart sounds. I'll observe for S1, S2, apex beat, and aortic and pulmonary valve. Then I'll also hear for any crepitus, any wheeze, any added sounds. And similar to the vocal resonance, the same thing I'll observe with the stethoscope also. So that is my schema of examination. Other than that, I'll also measure pulse rate, BP, and other vitals like saturation.
And did,
Uh,
did you remember to examine the chest of the patient from the back
yes, in the inspection part,
only?
Even in the percussion and auscultation also, and in the palpation movement, whether the movement is symmetric or not, that I'll observe from behind as well, from both from the front and from the behind.
Okay. What else are you missing?
I'll do CVS examination
Okay.
simultaneously for S1, S2 breath sounds. I'll just see whether how is the movement of abdomen while respiration, whether the breathing is thoraco-abdominal or not.
And
I'll do a general examination to see pallor, icterus, cyanosis, clubbing, lymphadenopathy. Uh, I'll measure the vitals.
you'll measure.
Pardon me?
What did you say? Did you say you will measure vital?
Vital, yeah, just to have an examination after general
Which
examination, I'll do the vitals like pulse rate, BP, saturation, SpO2.
you'll measure or you'll compare it with the patient's charts
Yeah,
of
I'll
all.
compare it with the patient's charts.
And what else would you do?
Input, output, measurement. After that, I'll investigate further.
How? What exactly would you do?
Since he's having a sudden onset chest pain and difficulty, I will. I'll do few tests like blood picture, full blood count, ECG.
No, on the spot you'll be doing that. No.
On the spot, we can do ECG, and
No. All right. Can you please summarize your examination?
uh, so here is a 55-year-old male who is a post-op day 8 right hip replacement. He developed sudden onset chest pain with difficulty in breathing with
Yes.
oxygen mask on his face.
Yes.
So on examination, on inspection, upper respiratory tract was normal, trachea was in midline. There was bilateral symmetric movement or in pulmonary embolism, the symmetric movement can be a bit disturbed, like one lung may move a little more than the left. Okay, inspection observed for movements of the lungs uh, to see whether the respiration was thoraco-abdominal or not, whether there was any paradoxical respiration. I observed from behind as well, whether there was symmetric expansion of both the lungs or not. On palpation, looked for the lung movements in the front and in the back as well. I observed for the apex of the heartbeat. Then I also looked for vocal resonance. In percussion, I percussed the intercostal space from front and from behind to see for any change in the percussion note. On auscultation, I heard for breath sounds. I looked for any added sounds like wheeze or crepitus. I have also auscultated the heart sounds, and I've heard for any additional murmur if at all present.
And there
So,
was none present. Okay.
no, not
So what are your provisional diagnosis for this patient?
my provisional diagnosis is uh, pulmonary embolism
Okay.
to
Right.
right hip replacement. Yeah,
Because of that. All right. Please tell me, you were already standing beside the bed and you were doing the investigations, but please tell me what investigations would you arrange for this patient?
I'll arrange for D dimer
Yes.
and
Yes.
blood count D dimer and probably ECG,
Yes.
and if possible CT pulmonary angiography,
Yes. And ABGs.
ABG as well. Yes.
Okay.
Yeah.
Please tell me what treatment of pulmonary embolism can you offer this patient?
First thing is I'll give supportive treatment like I'll prop up and then I'll start oxygen via oxygen mask.
He already has oxygen mask.
Oxygen mask.
Okay.
Uh,
More.
then I'll try to correct the electrolyte disturbances and ABG disturbances if at all they are present.
Is there
uh,
any pattern or any formula or any advice or any routine you'll follow for the management of this patient?
risk protocol.
Yes, good. You have to tell me this, right?
Yeah,
And
yeah.
then
Um, I
how much oxygen would you be giving?
maybe about 6 liter, 4 to 6 liters. It depends on the oxygen saturation.
Saturation of the yes patient. All right, then please
Uh,
continue. Bell is gone. So
so
we know that you're taking extra time. Yes, continue,
So
please.
I'll continue to give preventive measures for pulmonary edema so that pulmonary edema does not develop.
No, purple
Uh,
embolism first, please tell me.
embolism, I'll give a blood
What is the therapeutic dose of subcutaneous heparin that you'll be giving patient?
uh, uh, Clexane, 40,
Yes.
40,
How
40,
much?
40, 40.
Okay. Then this will be followed by what?
This will be followed by heparin 5000 international unit. Will followed by oral warfare.
Oral. Yes.
Oral warfare.
Right. Okay. Just suppose you are scrubbed, you're in OT, and your nurse comes and she informs you that patient has crashed. What would you do?
Uh, First thing is I'll secure the airway first.
No, you're scrubbed,
Okay,
and she comes and tells you about this patient's this situation.
okay.
This
Um,
has happened to the patient. Your nurse has told you. What would you do?
Same, I'll follow the Ccrisp protocol. Ask her to follow the Ccrisp protocol,
You'll
and
ask for the crash call. Someone else will go immediately and will manage it. You can't just leave OT right now, right?
yes.
Yes. Okay. What else? First, you thought of provisional diagnosis, pulmonary embolism. What else can you think of? Because patient is 55 and has sudden complaint of chest pain and SOB. And what would be your second differential diagnosis?
ARDS, acute respiratory distress syndrome.
All
Uh,
right, or myocardial infarction as second or third. Could even be atelectasis or pneumonia, chest infection,
yeah.
anything. All right. Okay, so what are the mistakes that you have done?
Uh,
What is the ideal situation always? Like, just suppose you have read the stem provided this bell went, you entered in the room, you introduced yourself to the examiner. I'm exam candidate number 88 or 24. All right. And then you turn to the patient. Patient is most probably sitting with the mask on or lying on the patient bed somehow, right? What would be your next step? You went, you introduced yourself to the patient, you asked for permission, and then what you do second time you've done it, one time you make mistake, but second time it's silliness. So I would request you not to ask too many questions to the patient. You'll ask for the consent. What
okay.
exactly would you say for the just to take the consent for the examination, please?
Is that okay if I examine you today?
Yes, examine your chest in
Yeah.
order to help you. Is that okay with you? Patient will not speak because patient has mask on his face. So what would you do next? Or maybe patient will nod or close his eyes and give you a signal that, okay, yes, go ahead. All right. What would you do next?
Maybe I'll try to tell the examiner and examine and tell him my findings.
No, 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 no. How you have reached to the finding? You've only taken the consent. Who will ask the patient to take the shirt off, or who will help the patient to expose the area you want to examine? See, this
Chaperon.
is not history taking. This is examination.
Chaperon. We can ask for a chaperon.
Why?
Okay, I have to undress the patient myself.
No, why? Why would you undress the patient yourself?
Yeah, usually that's not the way, right? Like,
Never, 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 never ever.
yeah.
So you think and tell me.
Okay.